Good morning, everyone. And I'd first like to thank the organizers for getting together this really incredible group of people all in one room today. It's a joy to be a part of this and to have the opportunity to provide some discussion comments on these two presentations. I think both Howard and Judy provided excellent descriptions of several fundamental problems in the long-term care sector. And I would applaud both of them for not stopping there and actually proposing some specific policy directions that we might take to start to solve some of these problems, because that's, of course, the hard part. So I don't have any major quibbles with anything that either one of them said, so I'm going to focus instead on providing some alternative perspectives and angles and food for thought on some of the things that they said. So let me start with long-term care financing and specifically the private long-term care insurance market. I certainly agree with Howard's pessimism that the private long-term care insurance market, unless things change dramatically, are not going to be the big solution that some people would hope it would be. That we've tried for many years to implement tax incentives that would really expand this market. And what we can probably hope for is that if there isn't some broader solution, that we can tinker around the edges a little bit and expand the market a little bit. But it's not really going to solve the whole problem. But I think the elephant in the room, the big problem that always emerges when we talk about private long-term care insurance is this idea of Medicaid crowd-out. The research on long-term care insurance, the private long-term care insurance market, is equivocal on many things. There's just a lot of things we don't know about the role of families, about all of these different reasons people throw out there about why people buy insurance, why people don't buy insurance, why the insurance policies look like they do, all the supply side problems. The research is actually sort of sparse in some of those areas, and there's just really not good, strong empirical evidence in a lot of them. But one thing that really is emerging that's very clear from the research is this idea of Medicaid crowd-out, that as long as Medicaid exists, there's a big portion of the income distribution that is never going to consider long-term care insurance. So I want to look at that in a slightly more subtle way, and that is this issue of the incremental cost and the incremental benefit from buying long-term care insurance. And this is not a new idea. This goes back to what Mark Pauly was writing about several decades ago. But basically, when people are deciding whether or not to buy private long-term care insurance, they face a huge cost in that these insurance policies cost maybe $3,000 or $4,000 a year. But the benefit that they get out of it could really be thought of as an incremental one. If they're anywhere close to, if they don't have a lot of assets to give up before they qualify for Medicaid, and that is, Medicaid is there as a baseline. If they need long-term care and they spend down their assets, Medicaid is there. So what they really buy with a long-term care insurance policy is an incremental benefit. They buy a little more choice. They buy a higher care facility. Like nobody maybe wants to go to a nursing home, and Medicaid nursing homes in particular are perhaps not that attractive. So they're really interested more in this sort of incremental benefit. But the cost is not at all incremental. You basically give up Medicaid, buy this expensive long-term care insurance policy. So anyway, we can think about tinkering around the edges and trying to even out the marginal benefit and the marginal price of self-insuring a little bit more. I think would be a useful policy direction. So for example, we might think about a home care only policy, a policy that people might value more in terms of the premium that they have to pay for it. We might also think of ways to make Medicaid itself more incremental, so it's not just sort of a yes-no, you qualify, you get that nursing home payment or not. Moving away from Medicaid, Howard already alluded to some of this, there may be ways in which we can leverage informal care, and that we haven't really as a nation thought about in terms of policy very much yet. There are a lot of examples of countries around the world that have instituted long-term care insurance policies on a national basis, and they have taken very different stances to how to leverage informal care to encourage it or not encourage it, usually to encourage it. Some Western European countries have decided to, for example, restrict benefits to families that have potential informal caregivers available. Other countries have specifically decided to pay family caregivers to encourage the provision of that care. And yet other countries have decided not to pay family caregivers because they don't want to sort of reinforce, sort of typical historical roles of females in the family and in society. So there are a lot of ways other countries have grappled with this, and we haven't really gone down that road of trying to think about informal care and how we can use it in the broader scheme of moving toward long-term care financing. So moving on to some of Judy's comments on sort of the public side, the Medicare, Medicaid side of long-term care. And I think she made the point very well that dually eligible individuals are sicker than the rest of the Medicare population, and duals with long-term care needs, not just the chronic conditions, but duals with long-term care needs specifically are even sicker. Another example of that is if we think about the nursing home sector, where about 1.6 million people get long-term care at any given point in time, people with long-term care needs who are in nursing homes have incredibly high hospitalization rates, and are certainly a very costly and in greater need segment of the population. Their hospitalization rates are about at least about 15% over a 6-month period, the people who are in long-stay nursing home stays. Those same people, then after that hospitalization, often cycle through from the long-stay part of a nursing home to a hospitalization to a Medicare-covered SNF post-acute stay in the nursing home. And the rehospitalization rates there are also quite high, almost 20% within 30 days, right? And that's compared to, the statistic we always hear about, 20% of the Medicare population rehospitalized within sort of 6 months generally. But this is just within 30 days, almost 20% of the people going to a SNF for post-acute care are rehospitalized. And then those same people often cycle back into the long-stay part of the facility. So these, are very costly individuals, and these are not just individuals with long-term care needs, right? These are individuals who are transitioning within a very short period of time between acute care and post-acute care and long-term care, and also are in need of primary care. And when you try to sort of divide those out by payer or by setting, those distinctions become necessarily artificial and have the kind of unintended consequences that Judy was alluding to. The same thing, I'll show you a slide on this, the same thing kind of happens for long-term care recipients who are not in nursing homes but are receiving care in the community. So my main point here is that, I'm re-emphasizing Judy's point, but people with long-term care needs are particularly sick individuals, are particularly costly individuals. And, both Howard and Judy at the beginning of this said how great we're starting off this conference with long-term care, right? I think we should resist the urge to compartmentalize long-term care and think about it as some niche that we don't always have to talk about, because these guys are the frequent flyers. These are the people who are getting admitted and readmitted to the hospital, who are the really costly part of the population. These are the people that we should be targeting when we're worried about the new hospital readmissions policies. I wanted to show this graph to sort of make a slightly different point about the focus on the duals. But I'll start by saying, this kind of, again, reinforces one of Judy's points. This is from some work I did with AHRQ, trying to develop hospitalization measures, potentially avoidable hospitalization measures for the Medicaid population using home and community-based care services. And we can ignore most of these because these are just different types of composites, but focus on this overall composite of ambulatory care-sensitive conditions, hospitalizations for ambulatory care-sensitive conditions. And what we have here is a comparison of different types of populations. So this is just the general population, and then we have all of Medicaid, and of course, Medicaid population is sicker than the general population, but the difference isn't that dramatic because these are the sort of, as Judy mentioned, the women and kids are in there as well who are quite as sick. And then this bar here, we have the dual eligibles. So clearly the dual eligibles have higher hospitalization rates than the Medicaid population overall. So this is sort of the flip. She was kind of looking at what happens among Medicare, and I'm looking at people who receive long-term care services. And these are general. This isn't just long-term care services, but I'm looking at more of the Medicaid perspective now. But the really dramatic difference, of course, is between these and these other bars. And that tallest bar is the dual eligibles who are receiving long-term care services in the community, who are receiving home and community-based services. And that obviously is dramatically higher. The hospitalization rates for that population is dramatically higher. So that certainly reinforces Judy's point that it's not just the duals, but it's the duals with long-term care needs that are really expensive. But then I also, on a sort of counterpoint, want to look at this bar, which is all of the Medicaid recipients receiving home and community-based services, right? And so that includes the duals. If we just looked at the ones who are not duals but are Medicaid only, that's about a third of this population, right? So of the people getting home and community-based services through Medicaid nationwide, about 2/3 are duals and a third aren't. And if we had just the Medicaid only, this would be a little lower, but it would be about 2/3. The hospitalization rate is only about a third lower than for the duals. So my issue here is that we seem to perhaps be overemphasizing the duals, right? What we have is the duals are really sick. Duals with long-term care needs are really sick. But really, the flip side of that is people with long-term care needs, whether or not they're duals, are really sick. And so, I think because of the ACA and because of recent legislation, we're really focusing hard on the duals. I had one grant proposal that I had submitted, 4 different times to various funders that didn't get funded. That was about disparities in long-term care, racial and ethnic disparities in long-term care in the context of public reporting. And, finally I turned it around and wrote it in the context, same proposal, wrote it about duals instead, and it got immediately funded, right? So, it's a popular policy thing right now. But I think that the danger is that if we focus on the duals, and I still think we should do it, and I agree, but if we focus more on integration of Medicaid and Medicare, we may be simply moving the boundary, this artificial boundary between those who are in need of long-term care, who qualify for Medicare, and those who don't. And those who are not duals are perhaps even a more vulnerable population in different ways, right? These are the sort of younger than 65 individuals with serious mental illness and other similar conditions. I want to diverge for just a second, because there are a lot of researchers in the room, and talk about what we don't know that would be really useful to know to think about these different policy options and evaluate them. One is, we always talk about home and community-based care and how it might save money. We really just don't know. We don't know really if we're pretty sure it's not actually cost-saving. It may be for some segments of the population. We certainly don't know if it's cost-effective. We think it may be. Certainly people prefer to be in home and community-based settings. But the research there really needs a lot more work in terms of, where is that tipping point? You have the economies of scale in a nursing home that just may overwhelm any, cost savings you might see for really sick individuals who are in need of sort of 24-hour care. So where is that tipping point? We really don't have good research on it. There's a lot we don't know about the role of the family in long-term care and long-term care decisions. Again, this is something that the literature has sort of tried to look at and keeps coming up with equivocal results, except for this Medicaid crowd-out issue. And then finally, and again, I think Judy alluded to some of this, but we talk about more coordinated care and more integrated care because it's intuitively obvious, right? It seems like a good thing. It must be a good thing. Health outcomes should be better. It should be cost-saving. But we don't really know that. There's a lot we don't know about, how much bang we get for our buck in some of these efforts to coordinate care better, and what some of the trade-offs might be, right, in terms of competition and innovation, for example. So that's my little divergence into what we really need in terms of the research and to make some of these choices better. In my last couple minutes, I want to go back to the title of the session today, which is Equity and Choice, and mention something we haven't talked about very much this morning so far, and that is this issue of equity and disparities in long-term care. Of course, over the past 10 years or longer, we've heard a lot about disparities of care across the healthcare spectrum. I argue often that disparities in the long-term care sector are even more entrenched, almost by definition, right? Because people with long-term care needs need them on a daily basis. And so, you're not perhaps going to go across the city to go to a high-quality provider like you might for your cardiac surgery, right? It's very much connected to neighborhoods and where people live. It's sort of, the same situation that our educational system is in. It's very connected to neighborhoods, and of course there are great disparities in the health infrastructure in different neighborhoods. So disparities are really entrenched there, and I think it's really important as we move down the road of different policy solutions to keep that in mind and think about what some of our policy solutions might do in terms of the unintended consequences for disparities. For example, an issue near and dear to my heart is that of public reporting. Again, it seems sort of intuitively good. Put more information out in the public about healthcare quality, and people will be able to choose better quality healthcare providers. And what we're finding in some of our research is that not only do Medicaid nursing home residents or potential Medicaid nursing home residents not really benefit from it in terms of changes in market share, but they may actually be harmed by it in that the really high quality facilities are now able to sort of select the more profitable Medicare and private pay residents, and Medicaid residents you actually see going less often to the really high-quality facilities after public reporting. And those are the kind of unintended consequences, I think, because disparities are so entrenched in long-term care, we have to keep in mind and think really hard about as we try to sort of improve choice and move down some of these policy roads. And I want to end on an optimistic note. And that is, I think for years, there's been an inherent pessimism among long-term care stakeholders about the ability to sort of solve this big issue of long-term care financing. And a major reason for that pessimism has been that, how can we convince the country to worry about long-term care when we don't even provide sort of basic health insurance for everybody, right? And when you look at examples of countries around the world that have implemented long-term care systems, the common wisdom now is that people, add these things on to whatever they have built before that. It's often countries already had some kind of national health insurance, some kind of social insurance model, and then they sort of fit the long-term care into whatever is in place at that time. Up until this point, we haven't had something, and we still don't, in place to sort of build on, hopefully with the Affordable Care Act. At some point in the future, we can say we'll have something to build on, and it'll make it that much easier, or a little bit easier, to build on the long-term care piece. Thank you.
I'm on record as supporting the idea that Medicare should take the lead on these issues. But I also work for the state Medicaid agency, and I'm fairly surprised that you would be surprised that states are the ones taking the lead on this. In Illinois, Medicaid accounts for a little more than 1/4 of the entire state budget, and of our Medicaid recipients, 20% of them are seniors, are disabled, and they account for 56% of our budget. So in effect, this is 13-14% of the entire state budget. Last year, we underwent massive cuts in Medicaid and still have about a 100-day bill cycle. Willie Sutton principle applies.
I agree with you.
If the feds are slow, we've got no choice. I also say that your ending line of saying that letting Medicaid takes the lead throws poor people under the bus implies a sort of categorical judgment about how Medicaid fits in the entire healthcare system. And we could speak, all of us, for hours on the problems of Medicaid. They are legion, but I'm not so sure that that's a fair characterization.
Yeah, I apologize. And it is because it didn't sound like one, but I believe that Medicaid plays an invaluable role in protecting low-income people who need health and long-term care. So, and states obviously have a concern. I spoke that way from the my perspective, that in focusing on equity, that everywhere people should have the kinds of protections that that we have talked about, and I believe that that poor people should not be. When I'm coming from the perspective of this population as Medicare beneficiaries, they are both Medicare and Medicaid beneficiaries, and as Medicare beneficiaries, I'm arguing that low-income people should not be treated differently from higher-income people. So it is no surprise to me that states are taking the initiative and do it, but we also, while I've said all these positive things, from the Willie Sutton principle, we watch a lot of care delivery innovations and operations that are money-driven, not care-driven. And it is the state governments and federal government are sometimes guilty of setting a cap on what we spend and hoping for the best. And I see it I'm not surprised that states are active. I am disappointed that at the federal level, the leadership that ought to be there is lacking, and the states, because of the fiscal circumstances, are very anxious to be able to achieve savings and in some sense to have access to the Medicare savings that will result, and that may even do some good stuff. I mean, if it's used properly. But we've all watched this a long time. States vary, experience vary, and when it's all about where the money is and not about the care, it is a matter, I think, of tremendous concern.
As a family member involved in this, I must say I feel sort of an incredible sense of risk aversion about a lot of these new proposed care models, even though we in fact get no coordination of care, and it would be nice if we got good coordination of care. But what role are the families playing in the political and policy conversation about policy innovation for this population?
I would think about the families really as two groups. There are those family caregivers for the frail elderly and those family caregivers for younger people with disabilities, particularly, for example, the developmentally disabled community. I think the latter group are actually quite effective and have a lot to say. I think the former group, those who are caring for parents, are terrible advocates. And I think there are two reasons for that. One of them is a practical one. If you have a DD child of school age, that child is being taken care of during the day, can go to school. You've got some time, and you can spend some of that time advocating, raising the issues that are of concern to you. If you're caring for a spouse or an elderly parent, there's no place for them to go, largely, and you're overwhelmed with the care. The other one, and I can't prove this, but it's sort of what I think may be a psychological effect. If you're caring for a child with a disability, the end game, if you will, may be that child will live a normal or close to normal lifespan, may be able to work some. It's hard, but it's a relatively positive outcome. If you're caring for a parent or a spouse, the end game is they die. And after they die, I think you probably don't want to relive this experience in front of a lot of politicians. I think you just want to move on. So I think for those reasons, there's a real difference, a real disparity in the quality of the advocacy between those two kinds of those two groups.
Julia Lynch, University of Pennsylvania. My question is, I think, in some ways related to Harold's. I was thinking, as you both were speaking, about death panels.
Gee, I knew we were negative, but I didn't.
Yeah, I'm going to go really negative. You'll see that later today, too. I don't have any happy endings for any of you. No, I was thinking about death panels in the context of this runaway train of capitation.
Yeah.
And it seems to me that there's a very real potential for politicization of capitation as a system that will incentivize the revocation of care. Mm-hmm. And so I wonder what you two see as the potential that might actually happen politically. Well, and if we see that, what do we do about it?
Well, we had, it wasn't death panels, but when we think about in the 90s and the HMO revolution and the backlash, it was for the general population, it was to precisely that. And actually, it was surprised at myself because it took me a second to remember that I had a reporter who said to me, aren't these the dual eligibles, aren't they the real death panels? So I won't answer the question, respectful of, in general, respectful, but you raise a legitimate question. And I think that the whole issue of the incentives of capitation to do less, not to promote efficiency, are that they do both, and that we have a lot of experience where they do less. The politicization of it, I think what we have in the Affordable Care Act, in accountable care organizations, are an effort to make them kinder, gentler, more gentler incentives, emphasis on performance standards, other protections, but and so they've not been politicized yet, but we always have it. And then you have to look at for which constituency. And the reason I'm speaking so forcefully is that this constituency, poor people are less able to protect themselves from this development than are the better off.
Let me take a slightly different view. Judy alluded to it. In the 90s, we didn't have the quality measures, and we certainly didn't have the focus on the quality measures that we do now. And I think that does have the potential to at least change the game. The concern is absolutely legitimate. You have a managed care company that's getting paid $500 a month per life. If it can't make it work for $500 a month, what's it going to do? Absolutely, but I wouldn't be entirely skeptical about it. I think there's some potential, and the other part of it is, again, as everybody's been saying, from the perspective of the recipients of this care, what they're getting now, the unintegrated mess of a system where no physicians talk to anybody else, where nobody knows what drugs you're taking, is pretty scary. So I won't say it couldn't be worse. It could be worse, but it could be a whole lot better.
But it's often said that it can't be worse, and that is not true. And that, just remember that.
It can always be worse.
Well, you hear it from people. Harold is expressing skepticism on part of, as a family member, and I hear from not a lot, but from I'm thinking of a particular individual whose care arrangements that she has managed to make and are quite good in Medicaid are at risk of being significantly disrupted. So.
Let me add something to that. I think the incentives under managed care are clear and they're of concern, especially with this particular population. So the research that we've done in the past may not actually apply when we talk about this particularly vulnerable population. But looking over the years of research, I mean, even though those incentives are there inherently, we actually haven't seen, huge health effects from the capitation incentive in other settings, right? And so it may be a fear that is unfounded in the end. And the other point I would say is that, average payment matters, right? And if you look at sort of smaller scale models like PACE, that's really a capitated model. Because they're paid enough, it actually works pretty well, and I think there haven't been those kind of concerns that the health outcomes have really suffered.
Right, but you have a lot of you also don't see the care management that you wanted to see, and you do see a lot of risk selection.
Sure.
My name is Richard Frank. Gene Marsh. No. So I think we've sort of moved into the extreme zone here in the discussion, and it's not that. Yeah, I'm sort of building on Tamara's comment, which is that I think that this is a vulnerable population, and it's one that you want to pay attention to. On the other hand, the bad thing isn't going to happen in the abstract. The bad thing is going to happen in the way the program's actually put on the ground and administered and designed. And certainly everything that I think we've seen from CMS in terms of the way they've started dealing with the state proposals in the contracts shows that they're being quite responsible and quite careful and are very aware of the vulnerability of this population. So, to some extent, I think that should give us a little bit of pause. The other thing is that and this goes back to the state perspective, is that if you look at where the troublesome rules are and where the delivery system disjunctures are and where the political flexibility is, it's at the state. Judy, you've worked in Medicare long enough to know that if you're going to do this, you get the Congress involved, and we understand what that takes. And so, I think that it's not surprising that if actually you want to make progress, that it's the states taking the lead. Just one last comment is that, on the subject of crowd out, which is sort of a first cousin to this, I have a plea for evidence that basically we know crowd out for sure based on simulations, not on any data analysis. And even if you take the largest estimate that's ever been made of crowd out, that still leaves 50% of the market on the table. And so, I think that, we don't know as much as we think we do, even when we think we know it, and that there's sort of lots of room for innovation here.
Let me pick up on Richard's for the first question, which is Sherry Gleed. Sorry. I'm still Sherry Gleed. Okay. Which is to Howard. We started to talk about long-term care financing, and one of the things that came up in conversations with people, most of us are health people, and we talk about it in terms of health, and this kind of goes to the crowd-out question as well. But it turns out an awful lot of people are not prepared for retirement, even in the absence of long-term care. Forgetting about Medicaid and all that, they just don't have enough money if they should be fortunate enough to live too long. So how about thinking, how do you think about the models that you've talked about in the context of a population that isn't prepared for retirement, even if nothing goes wrong with them?
This is a huge challenge, and you're right, it's not about health care. It's interesting, when I talk to financial planners, I very often get this story. I have a client who comes in to see me, they're 60 years old. I say, what are your goals? They say, I want to be able to retire at 65, I want to play golf, I want to go on cruises. Well, so how much money do you have? They say $100,000. The planner thinks to himself, boy, you're screwed. but trying to get the business talks about what they can do. And ultimately, as long as they're talking about the good things about retirement, the golf, the cruises, the rest of it, people are listening. They say as soon as they begin to talk about long-term care, they start to look at their watch, they're really kind of squirrely, and they get up and they leave. So you're right. I mean, you can't even get to the long-term care part of the conversation. You've got to get to the first part of the conversation. I think it's about education. Asking people, putting it in economist terms, asking people to reduce their current consumption, for this thing that they can't really quite see is really hard. And Americans just don't want to do it. So I think it's going to take a lot of education. It's not a very satisfactory answer, but it's the only one I've got.
That's the answer. Okay.
Okay, I'm not as well known as Sherry, Richard, or Harold, so I'll have to say my name. I'm Michael Millinson, also from the Kellogg School of Health Quality Advisors. Actually, was a commissioner of the National Commission on Quality Long-Term Care a few years back with Newt Gingrich and Bob Kerrey trying to grapple with this, which is his own education. So we mentioned. Which we've mentioned the Congress. So after hearing Judy speak, I figured those of us who supported the Affordable Care Act were Bush Republicans. So let me ask a question from a sort of a right-wing conservative point of view, which I tried to do this with one of the right-wingers and they avoided it. Equity can be bringing poor folks up, or it can be making middle-class folks think what it's like to be poor. We have eliminated or almost eliminated the so-called death tax. And kind of you think there's a conservative mantra from years ago, the government that's big enough to give you everything you want is big enough to take everything from you, right? So why is there a right to pass pass money on to your kids, if you think about it, right? Not being impoverished by medical care is you don't know where the end is, you have to have some assets. But in terms of why paying long-term care, you should be able to go on Medicaid and give your assets away, and we did this with my mother-in-law, certainly. It is a thing that if you're going to have a government that is very concerned, as a number of our people are, about the deficit, very concerned about what the government owes you versus yourself, it's a real issue. And if people sort of looked at it as, in fact, you're going to not be able to pass anything on to your heirs, because why should we as taxpayers pay for your long-term care when you can afford to? That would change the discussion. And I think there's an opportunity to raise that with Republicans who've eliminated the death tax on the one side, say, okay, well, what about the other? And that would be an interesting way to force thoughts of equity on the minds of people who think they don't have to worry about equity.
So when you say, tell me again what you're going to say to Republicans.
I'm going to buy down. So my mother-in-law, who passed on
Right,
mom's dad,
does not be able to pass in.
Why should I, as a taxpayer, let you pass on?
No, I think Republicans already like that. I thought maybe you flipped at the end. So okay, so this is always a concern about Medicaid, and is the argument that it is rich people are taking advantage of the taxpayer. There's clearly one. I know and there is more than one. But the thing is, that when you look at the overall distribution of resources among the people who are on Medicaid, they are not rich people. The people who with higher incomes, most of people who need long-term care, as Howard explained, get care at home from their family members, or if you have money, you purchase. You may purchase as well. So the evidence, when we look small, is that there are some who are doing that. When we look large, the vast majority of Medicaid resources are going to low-income people. There's a new study on looking at spend down in Medicaid and demonstrating that the population who spends down doesn't have resources. So it does happen. And I think broadly on social policy that it is hard to draw boundaries, and you have conflicting incentives, and there are times when the generosity of a policy, when you have a policy that's there to protect people, is also including some people who you'd rather not protect. And the alternative is to make the policy so mean that you fail to protect the population that you need to protect. And I think that's the problem there. And while I have the airtime, I just wanted to say, not that I haven't used it, is that, Richard, the issue, again, thinking big social policy as opposed to immediate efforts in managing social policy, I think people at the state and federal level are very committed to getting this right. But you mentioned the Congress, and you know about waivers. And when you move 500,000 people into a new arrangement and argue that it is going to be evaluated and held effective, you and what army? So it is politically, once you start moving that way, it is very difficult for even the best intentioned administrators to change. So that's enough said.
I want to, go ahead. I want to respond to your question with a story, if I can. And I know that you're all researchers and it's all about data, but I'm going to give you an anecdote. And it also goes to this issue of focusing on the duals only. There's a true story I heard the other day. Man is 93 years old. He's living at home by himself. His wife has died. He has a daughter who lives in another state who was working 2 jobs and trying to take care of a kid. He begins to suffer hip pain, not from any trauma, but just some hip pain. He goes to an orthopedic surgeon. The orthopedic surgeon says, you've got actually 2 hip fractures, 1 in each hip. But I don't recommend surgery because of your age, because of your health. What you need is about 5 weeks of rest and then some physical therapy, and I think you'll be okay. Well, this guy doesn't have anybody to take care of him. He's not Medicaid eligible. He doesn't have the money to go into a nursing home or hire an aide, but he's not broke enough for Medicaid. So he says to the surgeon, I can't. The surgeon says, well, the only other choice is the surgery. They do the surgery, and you probably know the story. The hip repair is perfectly successful, and now the man is dying in a nursing home because he can't recover from the surgery. Medicare is perfectly happy to pay for the hip surgery, the post-acute care at $600 a day in the skilled nursing facility, happy to do all of that. You've got a guy who needs relatively inexpensive care at home, which will allow him to recover from this. There's nowhere to go. So it's not just about impoverishing yourself to get on Medicaid or any of the rest of it. It's about those people, middle class, salt of the earth, regular people who get caught in this vortex. And it's not doing them any good, and it's not saving the system any, believe me, he's not saving the system any money right now.
Yeah, I had one other comment that it's not really about preserving the inheritance, but the sort of, and I don't think of this as really a political issue, but more of a sort of ideological or philosophical issue, and that is this idea of housing wealth. I think in this country, we really think of that as sacrosanct, and that if you need long-term care, you shouldn't have to give up your house, and you should be able to leave that for your heirs, et cetera. And I know that, you know, when I'm at conferences in Europe talking about long-term care, it's sort of an obvious point that if you have housing wealth, it should go towards your care, and that you sort of build that in. And it's something that I think Americans, it sort of transcends political boundaries, that Americans just feel very strongly that they shouldn't have to give up that housing. So that's why things like reverse mortgages that might really sort of ease some of the burden, you know, despite the problems with the actual products themselves. But those kinds of innovations, I think, could do more if we didn't have that sort of basic aversion, or if we could get past that aversion.
Okay, I think we have time for one more question. We'll have our break.
Okay, so I'm going to try to ask a question that's related to preventive care. I'm a nobody.
No.
Please.
My name is Kausar Karwa, and I'm a consultant in healthcare revenue cycle management, and my background is in healthcare IT implementation and training. I'm just passionate about healthcare in general and policy and all the things that are changing in healthcare. So my question is in terms of preventive care on long-term care population. In terms of, I know there's an issue with access to care sometimes. And everything being centered around quality of care for patient and reimbursement gearing towards quality of care. How do we, it's going to require some change in behavior on the patient population itself. Yes, maybe Medicare wants to lead it, Medicaid wants to lead it, but how do we change behavior for the patients to seek out preventive care in advance so that it doesn't get so bad that they keep on getting readmitted into the hospital or for long-term care needs? Do you have any comment?
Well, I would just say briefly, because I think that that your concern is also going to be addressed in payment and delivery reform discussion later, I expect. But I think that that is a piece of where delivery reform across the system is intended to go. It is to move away from simple reliance on a single provider to prescribe services for you, and to have an engagement between patients and providers and families and teams of providers for those who need a lot of care to make sure that the whole range of a person's life, as Howard talked about in his example, is being handled properly. And that's what these innovations are when best done.
Okay, well, let's give a round of applause to our panelists.